Dr. Ken Landau, thanks for watching. Let's talk about the carpal tunnel syndrome. The carpal tunnel syndrome is a condition where the median nerve going from the forearm to the palm passes through an area in the front portion of the wrist. It's a little tunnel. 3 of the 4 sides of the tunnel are made up of bone. The top part is made up of a thick mass of connective tissue, a ligament. It's called the transverse carpal ligament or the flexor retinaculum, and inside that tunnel is the median nerve and 9 digital flexor tendons. And anything that increases the pressure inside that tunnel causes problems for the nerve, causes problems, and that is what's referred to as a compression neuropathy. And the carpal tunnel syndrome, the pressure on the median nerve, that's about 90% of all of the entrapment neuropathies. Carpal tunnel syndrome is very important because it's a major cause of lost work days and workmen's compensation costs. It was originally described in 1854 by Paget, at least the canal was. Then 1933, the first decompression surgery for median nerve injury at the wrist was performed by a Canadian surgeon, but it wasn't really a popular concept until after World War II. In the early 1950s, a surgeon at the Cleveland Clinic, Dr. George Phelan, brought it to our attention. The carpal tunnel is about an inch wide in the front portion of the wrist. The pressure under normal circumstances is anywhere between about 2 and 10 millimeters of mercury. Consider that as contrasted to the blood pressure 120 millimeters of mercury over 80. Well, the average in the carpal tunnel, 2 to 10 millimeters, but in the carpal tunnel syndrome, it's increased to about 26 to 30 millimeters. Sometimes it could get as high as 100 millimeters. The pressure is increased as you bend the wrist forward or backward, increased by about 8 to 10-fold the pressure inside the canal. Obviously, the more pressure, the more damage. The damage is caused by pressure in the canal damaging the little capillaries that supply the nerve. When the capillaries are compressed, the nerve doesn't get enough oxygen and other nutrients, and that leads to the nerve dysfunction. Ultimately, it can lead to abnormalities of the myelin sheath or the nerve itself. And then additionally, those 9 flexor digital tendons, they can become inflamed through a variety of different diseases. And then if there happens to be some thickening or increase in volume from the tenosynovitis, then that adds further pressure to the nerve. Under normal circumstances, the nerve, as you bend the wrist forward and back, moves by about 2/5 of an inch. Well, with increasing amount of pressure and damage, there's more fibrosis, and the fibrosis inhibits the gliding of the nerve. That leads to contraction and traction with nerve movement. That leads to further problems. Now, the best practices for diagnosing the condition and then for treating it currently remain undefined. It's a very common condition. It's estimated that your likelihood of developing the carpal tunnel, at least at some time in your lifetime, is about 1 in 10, and about 1 in 5 people who have numbness or tingling of the hand and the fingers are really suffering from carpal tunnel syndrome. Remember, the major symptoms are numbness and tingling, principally of the fingers. That's the early symptom. Now, the diagnosis at least depends, and the frequency of the diagnosis depends on what we use as the criteria. If it's just the clinical symptoms, well, that's a relatively small group of people. But if we put the hand through some special kind of motions, maybe something known as the Phelan's test, then that can increase the number of people who are diagnosed with the condition. And then if we use electrophysiologic testing, that increases further the number of people. Even if they don't have any symptoms, we can make the diagnosis. Well, the diagnosis on average is in about 4 to 5% of the general public, especially in people who are around age 45 to 60. That's the most frequent age of involvement. But still, in people less than age 30, it's 5 to 10% of the people who have carpal tunnel syndrome, depending on the circumstances, the sex incidence. Traditionally, it's been thought of as a condition much more common in women than in men, but postal surveys in Sweden showed the incidence was equal in men and women, at least as far as symptoms were concerned, but in women over 65, It's 5 to 10 times more frequent in women than it is in men. And in many cases, it may be bilateral. Bilateral, again, if we do the electrodiagnostic test, even if you don't have any symptoms, can be bilateral in up to 70% of the people. The risk factors are, again, undescribed. So people say that if you're diabetic, especially if you're diabetic with a neuropathy, you have a greater chance. Menopausal women, people who are hypothyroid, people who are overweight, people who have arthritis, maybe osteoarthritis or rheumatoid arthritis or gout are at increased risk. But the risk is really small. It's a minor increase. Then there's wrist trauma. Pregnancy may cause fluid retention. Fluid retention obviously can increase the pressure. So too can any medical disease that increases the retention of fluid, kidney failure. Some people say it's increased in tobacco smokers and in people who overuse the hand or the wrist, oftentimes due to occupation, repetitive forceful hand or wrist movements, people who work in cold environments, people who are in the construction industries, electricians, and people who are foresters, people who are aircraft mechanics or dental hygienists. But their problem principally is pain, not numbness and tingling. People who are engaged in sports activities, baseball and bodybuilders, they seem to be at slightly increased risk. Genetically, there seems to be a predisposition, especially in early childhood onset of the condition. People who have space-occupying lesions like a ganglion cyst, obviously they are at greater risk. Interestingly, the Canadian Medical Association Journal recently published a study, and what they did is they looked at the people involved in the general occupations, general society. And what they found was that the incidence was about 100 per 100,000 patient years. Then they looked at people who were in the skilled trades, and they found that there was indeed an increase, but the increase was relatively small. It was about 30% increase. Then they looked at secretarial work, people who used the mouse and the keyboard repetitively. And they found that actually there was about a 20% decrease in the incidence of carpal tunnel. So the use of keyboard and the mouse, that's controversial. At most it seems to be a minor risk, but 2 recent studies showed that it wasn't any risk at all. The symptoms of the carpal tunnel syndrome are numbness and tingling of the fingers, not the palm. The nerve that controls the sensation of the palm leaves the median nerve about an inch before the median nerve goes through the tunnel. Oftentimes when the symptoms begin, you have some poorly localized symptoms, but ultimately the symptoms occur mostly at night, mostly numbness and tingling, oftentimes wakes the person up, the person flicks the wrist a little bit, seems to get rid of the symptoms, and over time the symptoms then become present at least intermittently during the course of the day, and if a person keeps the wrist in a peculiar position. So for instance, if you put it under a pillow when you're asleep at night and it's bent forward, that's most likely going to cause you some problems. On the other hand, if you're an electrician and you have your hand bent frequently, well, that might cause problems too. A lot of people complain of swelling of the hands, but that's not really clinically apparent. And over a period of time, the symptoms are not present just at night, then they become present in the daytime. And you may develop pain. Pain is present in about somewhere between 1/3 and 1/2 of all people who have the carpal tunnel syndrome. But remember, early on, the symptoms are numbness and tingling. Those are the principal symptoms. And with time, later on in the condition, you start losing the ability to use your thumb in a forceful manner. And that means that you lose dexterity, and you can't button your buttons, and you start dropping items. So the sequence of events, the numbness and the tingling, and then the pain, and then the weakness and the loss of the thenar muscle, that's the muscle in your palm right by the base of your thumb. But remember, no loss of sensation. Do the symptoms necessarily have to get worse? No, they actually don't. Over time, they can get worse in some individuals, may be progressive. When it's progressive, you lose the ability to use your thumb because of the loss of the muscle mass. And then you can develop some ulcers, some trophic ulcers on your fingertips and the finger pads. There's a disparity between the symptoms that the individual complains of and the amount of damage to the nerve. Early on, with a little bit of damage to the nerve, a person has a lot of symptoms. But as the nerve becomes increasingly damaged, then the symptoms seem to become considerably less because the hand is numb. The associations About 20% of the people going to have some pain in the forearm, about 15% going to have pain around the elbow, 8% going to have pain in the upper arm, and even some people can develop pain in the neck, less than 1%. Well, interestingly, there's an association with trigger finger. Somewhere around 20% of the people who have carpal tunnel syndrome, especially after surgical therapy, going to have a trigger finger. The course of the disease could be monophasic. You could have the symptoms and they could stay the same just forever. Or you could have self-limited symptoms. Or you could have symptoms that seem to come and go over a period of time. The symptoms can be stable for a long period and then become slowly progressive. Or the symptoms can just disappear. You don't have to have the symptoms anymore. The diagnosis, well, we put you through some maneuvers. We have you flick your wrist and see if that causes the symptoms to get better, the numbness and the tingling. Then there's Tinel's sign. So we tap our fingers over the carpal ligament and see if that makes the symptoms worse. We have the hands flexed in what's known as the reverse prayer sign. And we keep the hands like that for about a minute and see if that recreates the symptoms. Or alternatively, we can do the prayer sign where the wrists are forcefully extended for about a minute. Or we can simply do the Durkin's compression test where we have the person put the hand on the wrist and then put our fingers over the carpal tunnel syndrome and press with 3 fingers for about a minute. And that might recreate the problem. Well, those are very frequently done, but they're not very accurate. The sensitivity to make the diagnosis is somewhere between 30 and 60, 70, 80%. We can't really rely on them for making the diagnosis. They're actually better making the diagnosis at tenosynovitis than they are at the carpal tunnel syndrome. Probably a better test is just put your hand over your head, keep it there for about a minute and see if the symptoms appear. We can test the muscle strength of the thumb. We can have you put the thumb toward the ceiling when your hand is on the desk and see how much pressure it takes to push the thumb back to the desk. We can compare it to the other side. We can look at the muscle to see if the muscle is atrophied or weakened or lost. We can test with a tuning fork. We can do what's known as the Boston Carpal Tunnel Syndrome questionnaire. We just have a person fill that out. It takes a relatively short period of time. We gain a good idea about the symptoms that the person has. The standard diagnosis is clinical examination. We don't need any further studies. Maybe if a person has diabetes or thyroid disease or kidney disease or gout or some other kind of medical condition, then we could evaluate a little bit further. There's controversy about whether we need some electrodiagnostic testing. There's little evidence to support its use. In the routine examination, now, we have several different kinds of electrodiagnostic tests. We have nerve conduction studies and we have electromyogram. We have a difference of opinion. The American Academy of Orthopedic Surgeons says routinely we should do the test. The British orthopedic surgeons and the British Society for Hand Surgeons say, nah, the tests aren't really appropriate unless we're going to perform some kind of therapy or unless you happen to be in a primary care setting, but certainly not necessary for most specialized centers. Nerve conduction studies take about half an hour, and they're relatively uncomfortable. Give us useful information? Sometimes it does, but not always. Could give us confusing information, but can tell a little bit about whether the nerve has been damaged. The electromyographic testing, again, probably for the overwhelming majority of people, an unnecessary test. Doesn't give us useful information for the majority of people, but might be appropriate if the person has peculiar symptoms or if the person has gone through some minor therapy and before we consider surgical therapy. X-rays unnecessary for the overwhelming majority of people. So too, CAT scans and MRIs are unnecessary in the overwhelming majority of people with the carpal tunnel syndrome. Sometimes ultrasound examinations are used. That's getting to be more popular. It can identify areas of increased pressure and injury to the nerve, but early on in mild carpal tunnel syndrome, the test is only accurate in 30 to 50% of the cases, and having negative information from the ultrasound examination really doesn't usually change the therapy. Are there other conditions that can cause some numbness and tingling? Sure. You can have osteoarthritis in the neck and can have a cervical radiculopathy, or some people can have diabetes or hypothyroidism or vibration injury, Or maybe you have a central nervous system abnormality. Maybe you have a small cerebral infarct. Maybe you have multiple sclerosis, or you could have brachial plexopathy. That can cause symptoms. Well, what do we do if you have the carpal tunnel syndrome? Well, we realize that we want to relieve the symptoms and prevent further deterioration, but we know that the symptoms are going to go away in at least a third of the people or more if we don't do anything. So there's education. Don't do those movements that seem to bring on the symptoms. If you happen to have a keyboard, put it at regular height, decrease some of the repetitive movements. If you're overweight, lose some weight. If you're diabetic, control your diabetes. What about the splinting and manipulation? Well, we can stretch the muscles of the finger, we can massage, we can exercise. Splinting itself is pretty good. It's inexpensive, certainly. Well, there are only poor quality studies that suggest it's beneficial. It should be used for at least 4 weeks, preferably 8 weeks. Using a splint full-time is better than a splint just at night. Keep the wrist at 0 degrees of extension. You can get a prefabricated or a custom-made splint. Both of them work seemingly, apparently equally well. And if we use the splinting, in those people who were told they'd have to go for surgery and we were just doing the splinting to wait until surgical time became available, after 8 weeks, 2/3 of the people said, hey, I don't need any surgery. I seem to be better. Injections of steroids into the carpal tunnel, that seems to be helpful for some people, but not appropriate for everyone. Certainly the injection should not be into a nerve or a tendon. Don't do it if there's advanced sensory loss or if there's muscle weakness or muscle loss at the thenar muscle, or if you have acute carpal tunnel syndrome. There are some problems that may occur due to the injection. You can have local infection, you can have injury to the median nerve, you can increase the likelihood of tendon ruptures, and some people develop a horrible condition known as complex regional pain syndrome, or used to be called the reflex sympathetic dystrophy. Injections don't seem to work very well if a person's older, if a person has longer duration of disease, more severe disease, or if a person has diabetes or has permanent symptoms. Any of the steroids seem to be effective. Oftentimes they're combined with procaine or xylocaine, something to help reduce the pain instantly. But on study, the injection doesn't seem to be necessarily superior to splinting and taking an aspirin or a nonsteroidal anti-inflammatory drug. Well, if you're going to get the benefits are going to come within about 4 weeks. The symptoms are better than placebo by 10 weeks, but unfortunately, by a year and a half, you only have about 11% of the people who are benefited by the injection. So what do we want to do? We want to choose a conservative therapy. Conservative therapy because overwhelmingly the symptoms are going to disappear after about 6 to 12 months. So we change the habits, we do some pain reduction with pain pills or ice or heat or splinting, or some people even use some low-level laser therapy. And then ultimately we might include some of the injections. Then there's consideration of surgery. Surgery if the conservative approach fails, if there's progressive motor deficit, or if there's severe sensory deficit. If we have severe electrodiagnostic abnormalities, so we want to prevent further deterioration of the nerve. All of those are possible that incline us to do some surgery. Release of the carpal tunnel. Surgery is done about 600,000 times each year. Simple procedure, takes about 10 minutes. Typically it's an open procedure with a long incision. Now people are doing it with a shorter incision. Some people will do it actually endoscopically, or can do it as a closed procedure. All of them are office or day surgery procedures under local anesthetic. The failure rate can be as high as 25%, oftentimes with an incorrect diagnosis or an incomplete release of the tendon. About 5 to 10% of the people are going to have second surgery, open surgery, multiple different techniques. Endoscopic surgery isn't all that widely done because it has a relatively steep learning curve and it's more expensive and it has more likelihood of damaging to the nerve, so not done. If you have bilateral disease, you could have both of the wrists taken care of at one time, but the people who have gone through it, when asked if they would do it again, they say, no, I'd rather do just one wrist at one time. Well, if you have surgery, then there are complications that go along with it: nerve injury, tendon injury, artery injury, and then there's that complex regional pain syndrome again that causes hand pain and sweating disorders, vasomotor instability of the hand, and scar tenderness is very frequent. Sometimes you have decreased grip strength. You shouldn't have the surgery if you have rheumatoid arthritis, if you had the prior surgery with a complication, or you have ulnar neuropathy. Those would suggest a much more conservative approach. 1-year follow-up. If you have moderate disease, only 2% of the people are going to have remaining symptoms. But if you had severe disease, probably 1 in 5 people are going to have remaining condition, remaining symptoms. The likelihood of a poor outcome is increased if you're diabetic, if you have poor health status, if you're using alcohol or cigarettes, if you have outstanding workman's compensation claim, if you have normal pre-existing conduction studies, if you have noticeable wasting of the muscle of the thumb, variety of other conditions. Certainly a wrong diagnosis likely to lead to a bad outcome. We have to consider, what is most important? Is the reduction of symptoms most important, or is prevention of damage to the nerve more important, even in the absence of symptoms? Something to consider. Other kind of therapies, the gabapentin is basically the same as a placebo. Lidocaine patch doesn't seem to help. A diuretic, a vitamin pill, amitriptyline or vitamin B12 or vitamin B6, not helpful. Some people claim that low-level, low-power laser therapy, light therapy, seems to be helpful, seems to be about as helpful as a placebo, maybe a little better than a placebo. Magnetic fields, again, not something that's quite beneficial. Therapeutic ultrasound, nope, doesn't seem to be helpful. Some people use extracorporeal wave therapy, sort of the same kind of shockwave therapy we use to treat kidney stones. Some people say it might be a little bit helpful, but not very widely used. Acupuncture may provide some relief. There's no evidence that chiropractic or yoga or other therapies seem to be helpful. Interestingly, the prognosis seems to relate to a person's mood and a person's mental state and a person's use of alcohol. So that's the story of the carpal tunnel syndrome. It's very common, associated with numbness and tingling of the thumb and the index finger, the middle finger, and the inside portion of the ring finger. The symptoms tend to come and go. Originally, they're worse at night. Later on, they're present during the day. They especially worsen with flexing of the wrist, repetitive action. Seems like a splint and some painkiller is the way to go for the overwhelming majority of people. Most people will not need an injection, and only a few people will need surgery. So anyway, that's the story. Thanks for watching. If you enjoyed the show, please tell a friend, maybe consider subscribing. We always appreciate your interest. I'm Dr. Ken Landau.